All right, this one's about the same number of slides. See if we get through it a little bit faster. Head trauma. Can't do anything without talking a little bit about some anatomy and physiology. And, well, I don't want to say I don't care that you know all the little parts of the bone, of the skull, because that's not true. But there's a lot of little stuff in this too, like this ethmoid bone that, I don't know if I've ever had a patient that has fractured their ethmoid bone. But we start talking about things like the occiput, parietal, frontal, just so you have some idea of what part of the skull we're talking about. Nasal is good, maxillomandible, temporal, that's probably good. The zygomatic is the cheekbone. That's one that we're supposed to have the high cheekbones to be pretty. In my martial arts classes, I get asked a lot about how to take your palm and drive someone's nose up into the brain and kill them in one blow. And I say, I don't know, because I can't think you can do that. If you look at the nasal bone, it's actually very small. Most of this is just cartilage. So if you hit somebody and you drive it up, it's really not going anywhere. And it's sure not going all the way through the frontal bone and up into the brain and killing them. So I don't know where that came from.
Oh, it's a movie.
Yeah, a movie.
Yeah.
It's not it's not a bad strike, because you do that and you get a nosebleed and it's hard to breathe, eyes water, it's hard to see so they can't fight as well. I mean, I'm all for that, but I'm not going to be able to say, oh yeah, you just do that and you can kill a guy. If that was the case, we have a lot more dead people, I think.
Well, listen, another deadly nose blow kills 6.
One of the things that you can have a fracture is you can actually fracture through here and across that and down the other side. And then the face kind of falls. So there are different types of fractures through that, but that's one that we will see occasionally for somebody getting hit hard or steering wheel or something. But it's just, I look at the skull and when they have it colored like this, I just think it's kind of cool. But now the brain inside it is a little bit more interesting, I think, than just the skull. The skull's okay. I kind of like it, but the brain inside is interesting. Remember, you have 3 basic parts to it. We have the brain stem, and part of it is pons, part of it is the medulla oblongata, but this is all of what we could call the basic functions. So this is going to be the area that controls pulse rate, respiratory rate, blood pressure. All that is in there. Our vomiting center is in there, and that's going to be important later. This area back here in the cerebellum, kind of think consciousness, which is really weird. How do you know if you're awake or asleep? Kind of mess with your sleep tonight. I want you to imagine the moment you fall asleep. I want you to remember that when you wake up in the morning. So I have to sit there and think about, oh, I'm about to sleep. Oh, wait, now I'm awake. You can thank me on tomorrow. Having to drink an extra couple cups of coffee because you didn't sleep any. And then this is all higher function stuff. And I don't know if we could truly live without all of it. But if parts of this get damaged, we may not have a fully functioning body, but we could live through it. This here we can't. Personality, behavior, in the front. And I mention that because people that get a head injury here, or they get a head injury here, and the brain bounces, and they have some coup contra coup, but have the frontal part of their brain damage, may have some personality changes. And I very rarely have had the person that has like centered their head on the dashboard or the windshield, and you see the spider web, get out of the car and be like, oh, it's so nice to meet you. I'm glad you came to join us today. No, they get out of the car and they're like, I'm going to kill you, mother. They always want to fight with us. I don't get what that is. But head injury patients can be a little bit on the irritable side. Now, depending on what other part gets damaged, they may have some different changes to their body. We have meninges that surround the brain, layers. You've probably heard of meningitis. That's the area that gets inflamed. And then we have the skull on the outside of that. Now, scalp injuries bleed a lot. you ever cut a face or something, there's just gonna be a lot of blood. You have a lot of blood vessels in this thing. Some of the worst I have seen have been due to either the rearview mirror or the sun visor, where instead of pushing it all the way forward to the windshield, they leave it tilted towards them, and they hit something and it hits their skull and actually will scalp them. I don't know if that's politically correct to say or not, but it'll scalp them. And the first time you see that with the scalp all flip back, and you're like, oh, that's their skull. You're like, oh, that's kind of cool. Don't rap on it, by the way, but it is kind of weird. It's like, that's like the skull that you see there.
I read that call. Did you hear about the 18-wheeler wreck a while back?
No, there was a big one I know yesterday that I had to deal with.
It was like in October.
Oh, yes.
Where this whole forehead of the young lady was gone. I read that call and I saw that. I was like, oh. I was like, that's that.
Yeah.
It's nasty.
My first scene, skull and brain, was a construction worker, and he didn't fall that far. He slipped off of a platform and fell, but he hit his head out of a board, like a 2x4 that was sticking out as he went down. He only fell like 7 or 8 feet. Yeah. But it managed to break it and splatter when he hit the concrete. It's one of those things when the first time you see it, and you're like, ooh, okay, I get it now. Yeah. That's not supposed to. But all these things, these injuries to the skin will bleed a lot, and we have to be a little careful, because normally you'd say bleeding, direct pressure. Well, that's okay, but when you like put direct pressure on that, and you're like, oh wait, that's kind of mushy. No, and then you have to be like, ooh, because that's now a skull fracture under the laceration, and the bone ends, you're just like embedding into the brain. So don't press too much on that, but then like, where do you press? And then you have to try to create pressure around the skull fracture. And if you can see where it's squirting, maybe you can get a finger and hold pressure right on that. So you have to be a little more cautious with just doing the heavy direct pressure with head injuries. Now, the skull injuries, like other fractures that we've talked about, different ways that we can break them. A lot of them are what we call linear fractures or cracks, and you probably won't identify those in the field. But the skull is just sort of cracked through there. Short of an x-ray, we're just not going to see that. Now, depressed skull fracture, we have part of it cracked and other part of it cracked, and then it gets sunken in. That you may see, or you may, when you palpate, go, ooh, that's cool. Again, don't be like, oh man, hey, cool, check this out. Put your fingers in there, because you're pressing on their brain, and that's not real cool to the patient. You can maybe pad a little bit around it and just make sure people don't mess with that.
People used to do that to me on my soft spot as a baby. This was wrong with me.
Okay, yeah. Well, babies, we can do that too. They're young, they bounce back. So closed versus open. A closed fracture, I always worry because it's under the skin, maybe not see it, but depending on how that is cracked, is there enough room for swelling? Now, not that open fractures are better, because those are usually fatal. When you see not just the skull, but you see the brain underneath it, those are usually fatal, but not entirely. And probably the biggest example, I don't know if any of you remember, probably about 10 years ago now, guy in Norway went crazy, got on an island with a camp, shot and killed a bunch of kids, like 70 of them, blew up some stuff before they finally, I don't know if he killed himself or somebody killed him. But one of the first officers that arrived on this island, this camp, and was walking by and saw all these kids, looked at this one kid whose skull was open and his brain was out. And he just kind of like peered it up and put it back in there and put the skull on, and then went on to the next one. He's like, oh, that's dead. But when the medics got there, like, oh, he's still got a pulse. And he took him to the hospital, and he's not exactly like he was before, but he's not bad off. I'm like, how do you like put somebody's brain back in their skull and kind of cut the skull back on it and have that be okay?
Connected to the spinal cord.
Yeah, something must have just been connected right, and it all just, but kind of an amazing story. Maybe a little bit closer, Gabby Gifford, the congresswoman from Arizona, at one of her rallies took a shot through the head. I shouldn't joke about it, but it's interesting that she, as a congressperson, can get shot in the head and then go back to work and everything's okay. If I got shot in the head, I don't know if I can make it back to work, but Apparently you don't need a brain in
Well,
Congress.
you don't even.
Well, if this new batch, any proof, I don't have to agree with you on that 100%.
Apparently with her, it went right through the fulcrum, the split of the left and the right. So it never really did damage the brain much other than a little bit of concussion force. But talk about a lucky shot for her. So open wounds, you can't see the brain, and this might be a time I'm a little less hesitant to like get out the saline and irrigate too much, clean too much. I would not do pressure like I would a normal wound with a syringe. I might rinse off some of the dirt and things and then cover it up if I saw that. Now the basilar, I want to mention that one because with a basilar skull fracture, that's the base of the skull. So you have a little bit of bone that kind of runs right along through here. And if that fractures, it usually causes bleeding in one of two areas, either in the ear or behind the ear. So you'll see bruising back here, which we call battle signs, or you have the fluid coming from the ear, or you'll see periorbital ecchymosis. I always want to say the British.
Eyes.
Yeah, raccoon eyes. So both of them will be black and blue. Now I have had some good blows in sparring, and the next morning I'll have 2 black eyes. I don't think I've ever had a basilar skull fracture. If I haven't gotten it x-rayed and diagnosed. That may explain some things. So I have a hard time going, what is periorbital ecchymosis, raccoon eyes, versus you just got popped in the face and got a black eye, or 2 black eyes. So that one I'm a little bit harder.
Well, usually
picking
with
out.
the raccoon side, there's not really a lot of swelling around the eye
That's
itself.
true. That's true.
Whereas you get
Yeah, it's gonna be
soft eye, you're
swollen.
going to see signs other than underneath the eye. You can see top, around, possibly to the sides, but not necessarily all the way underneath the eye itself.
That's true. Maybe that's a good way to
That's how I
differentiate.
was told how to do it. Between, well, how do you tell between you got guy who got punched in both eyes and that? And, well, that's how my instructor said. Well, you get
Not much soft tissue.
Yeah.
I'll go for that.
a lot of deep ecchymosis.
What I want you to know about this is if you suspect a basilar skull fracture, because the base runs right along here, don't put an NPA in. I've never heard of it truly happening, but that's the concern, is that the base of the skull is fractured, and then I put the nasopharyngeal airway in, I could put it right through the fracture and up into the brain. And oxygenating the brain is good, but it's better when it goes through the lungs and the bloodstream and not directly into the skull.
Are you still looking for that basilar by the fluid that's coming from the
Yeah,
ear?
if I see
See
fluid
the
from the
4x4 ear, you get that little circle in it.
The halo test, I mean, if you do it, you can be like, yay, but it's not really all that accurate.
Okay.
So they say it's, because plasma will leak a little bit, just the normal plasma of the blood, that will look a little halo-ish. So it's really not a great test for us. But if you see blood coming from an ear canal, I would not be sticking a nasopharyngeal airway in them. I would suspect it. So I'd much rather err that way than the other. If you want to do it, go, hey, look at that. That might be the time, like, hey, come over, check this out. Can you come check this out? You can start teaching in the middle of the scene.
Yeah, there you go. His eyes twitching, but he'll be all right.
So, I did not make this slide. This is the one that came with it, but I thought, yeah, I'll leave that one in there. So ways that we can hurt the head. No reason to leave it in there so we get kicked upside the head. Although I'd like to think that I have enough control that I don't kick too many people upside the head that don't need it. But I know I've had more than my fair share of concussions from martial arts training. But any way that we have trauma, we can have head injuries. Assaults, car accidents, falls, sports, football. We know all those ways. Well, we're going to talk about different types, but I want to mention the diffuse axonal injury. A closed head injury, again, everything's intact. I'm a little worried where the swelling's going, and we'll talk about that in a minute. Open head injury, of course, I'm worried about infection of the brain matter, but at least the swelling isn't as big of a concern. This diffuse axonal injury, this is when you actually damage or tear the axons between all the neurons. And a lot of times this person is hit so hard that they've shifted their brain and these have torn, and it's usually fatal. Although there's some of this that may happen from a brief strike for like a knockout, but usually diffuse axonal injury is real severe.
That's what happened to, just lost that racer's name.
Andrew?
No, the racer, number 3,
Aaron? No.
Earnhardt.
Aaron, okay.
That's what.
I'm not a
that's
huge
what happened-
racer.
That's what happened to Earnhardt, and when he hit the wall so hard, and everything caught, his brain hit the front of the skull so hard, that's what caused it.
Tore all those axons and
Yep, that was it.
gone. Now, this is one that we've gotten a lot of publicity about later, or recently, not later, but lately. Because of all the stuff with the NFL and repeated head injuries and the fact that they tend to commit suicide at a much higher rate, and they all have Alzheimer's, and most of them don't really know who they are by the time they're 60. So,
That would be some of that movie Will Smith was in.
yes, yep. It's a really good movie, actually. I've watched it several times. I think this is probably a bigger deal than what we have given it over the years. I'm a little worried that we have taken it too far now.
Doctors now, if you look in there, I mean, it's gotten to the point, and I'm just saying this from experience, okay? It's gotten to the point now where the coaches are wanting the trainers to evaluate your child first
Well, there's a reason.
before you go to the doctor, because doctors are so scared of that movie, because that was based off a true story.
Oh, yeah.
They're so scared of that malpractice lawsuit now. If you go in there and say, I got hit in the head yesterday and I've got a headache, boom, concussion. You know, and you're out 2 weeks.
Yep.
And you don't even have one. You know, but they're erring on the side of caution so heavily now, it's crazy.
One of the things that's hard about this is we don't have like a real good test for concussions. Now, the last year, 2 years, there's been a couple of things that have come out. There is a test that can be done, but what has to be done is prior to like the beginning of the season, all the players have to go through a screening, because it's a timed test. And they go through this thing, and they do it all, and it's timed, and boom, the time is written down. So then they go out and play, and one game, boom, they get hit, and they're down, and they're kind of like, whoa, and then they kind of stagger off. The trainer sits them down, runs them through that same test, and if there's an X delay from what their baseline is, you've got a concussion. Pretty accurate. The problem is, I don't screen every patient I ever run into before they have their wreck, before they get assaulted, before they whatever. So it's worthless to me on the ambulance. It's good for a sports team. So I need something different or better. And we do have a blood test now that's in its early stages, and it looks to be very promising. So far it's been pretty darn accurate. But I don't know if we're gonna get that pre-hospital. That might be one of those that draws some blood, run it through a machine at the hospital, and then this marker comes up high, yes, you have a concussion. That would be great if we can do that, because then that saves that, oh, you hit your head? Do you feel dizzy at all? Do you have any sort of lightheadedness? Do you have a little bit of, does it hurt any? Concussion, you're out for 2 to 6 weeks.
Yeah.
So hopefully we'll have that before long. Now my last concussion, and I didn't go to the doctor for it, I got popped in the head and I knew it, saw the stars for a moment, thought, oh, that was dumb. I dropped my hands and he hit me. Taught me a good lesson, not mad with the guy. Should have kept my hands up better. But I had a headache for like 6 weeks. So in hindsight, I'm like, yeah, that was a concussion.
My last one, it killed me.
Yeah, keeps you down for a while.
For like a couple months, dude.
Concussion TDIs are no joke.
They're not, no.
I think I've had four of them when I was in the service.
Airbag.
That's why I'm on
supposed to
8
save
kids
your life.
right now.
Mine nearly killed me.
The problem is, we don't have a treatment really. And we're not even really sure if the stay home and rest is good, or do you have a little bit of activity? We know getting one concussion and then another on top of it and another on top of it is bad, but we don't know things like, well, what if you just like go lift weights? Is that a problem? Is there something they could be doing? And we just don't have enough data on all that yet. So initially when everybody started having this and everybody was saying, they're like, go sit in a dark room for like 3 weeks. No sensory input. And now they're like, that was probably not real good. But we don't know what is good. Us as EMS providers, we need to be the advocate for our patients and the advocate for our players if we're working the game. And the saying is, if in doubt, sit them out. And the thing here is, we know that repeated concussions, repeated brain injuries, even subconcussive incidents, minor stuff, adds up. So if somebody gets their bell rung, they're confused, they're going the wrong way, they're not sure the score, they can't remember everything that happened, sit them out. And I see us, because we're sitting there on the sidelines in the ambulance as the standby crew, and some coach or trainer saying, hey, let's come over and check this kid, because we're the medical professionals. And we get there, and they're like, what do you think? If you've called me over because you got that big of a concern, my reflex answer, sit them out. Of course, now dad's yelling at me because their son isn't playing, coach is upset because their star player's out, kid wants to get back out there and play because he didn't want to let his team down, and you're the bad guy. So just be ready for a
You be
little
the
bit.
bad guy, then the guy who says nothing and the kid, boom.
I agree with you, but just be ready, you're gonna face some, especially if it's like a really big game. And you're doing this standby in your hometown, you graduated from that same high school and everybody knows you, and so.
I had something like that because we have guys who work out so hard stuff that they get so dehydrated that they'd, all the film status and stuff like that, and I'm the medic here trying to make sure everything is good, and this guy's, I mean, he's got maybe, Glasgow, maybe 8, 9, I'm going,
Yep.
and take them out and then give him, food and say, no, you're not gonna do this anymore, go sit down and, recover.
Yep.
And I've gotten in so much trouble for that.
Well, that's where I said you have to be the advocate for your patient, do what's right for your patient, regardless of what other people are saying. I don't have a problem with it. My high school football team, I think won a game 4 years I was there, so football wasn't a big deal. I don't mind sitting the player out, but I'm also not from here. I don't understand this whole small town Alabama football thing.
I'm from here, and I still don't understand.
But I know it's big down here. Now, a contusion is when we have a bruising to the brain. So this is generally a step up from a concussion. If you x-ray, CAT scan, MRI, concussion, won't see anything there, no changes. Now, down the road, you get some chronic traumatic encephalitis and brain wasting and things like that, we can see that. But pre-hospitally, immediately after the incident, nope, not going to. But what happens when we have a bruise? We have swelling. So this is something that might be identifiable with the right imaging stuff. We're not gonna see it pre-hospitally, just realize this is worse. They generally are unconscious or had a period of unconsciousness and don't remember what happened. So the nursing rhyme, training is pouring, the old man is snoring, he bumped his head, went to bed, and couldn't wake up in the morning. With a subdural hematoma, they typically will hit their head, may have a brief loss of consciousness, wake back up, and then this slow bleeding will occur over several hours. So he bumped his head, that's when the injury happened, bleeding started, but he went to bed, probably because he had a headache, maybe a real bad headache, but then that bleeding occurred all night long, and then he never woke up again. And that's classic. Now, why the old man? Why not just a man or the man?
Does it happen if we,
It can happen.
What happens to our brain as we age?
It shrinks.
It shrinks. So now there's more space. So when the brain or the head hits and the brain moves, body in motion stays in motion, those bridging vessels get stretched even further. So they're more likely to tear. Plus older people, a little loss of balance, much more likely to fall down and hit their head. But that's part of it. This happens in older people, typically more males than females, but it can happen in both. Now there's one other kind of risk factor, well there's a couple of risk factors. One other thing about being older, heart disease. Have heart disease, atrial fib, other heart disease, what are they on every day?
Blood thinners.
Blood thinners, taking an aspirin every day. Now they tear a little blood vessel, it's not gonna clot. It bleeds, 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 bleeds. So there's another thing that has older people, especially with heart disease, have to deal with these. And then the last one is alcohol. And it's subdural hematomas happen to all people, whether you drink or not. But if somebody has drank a lot over their lifetime, especially a chronic alcoholic, their brain is shrunk even more. So then they can stretch even more and cause more problems. So they may have unequal pupils, loss of consciousness, typically not responsive anymore when we get called. Almost a little bit like a stroke, but there's a history of them falling. And if you ask and can really truly go back over the last 6 months, year or so, a couple of years, they probably had some other falls, and they've had very small hematomas, subdural hematomas. And we call those the occult ones. So we just didn't realize that they had it. They bumped their head, they went to bed, they did wake up. So I don't know if it recorded the first part or not. I hope it did. Otherwise, I'll have to sing the nursery rhyme again. Thank you. So that's the occult. The acute is what we usually get called for. That's when they fall a few hours later. They're not acting right anymore. Epidural hematoma. This one's kind of cool as the martial artist because I want to do the one strike, one kill, boom, and be able to drop them. Temporal bone, fairly thin. Right underneath there, you have the middle meningeal artery. So you get hit, boom, hard enough there, and that can damage the meningeal artery. It's an arterial bleed. So now they may get hit, they may lose consciousness, they'll wake back up, but because it's an arterial bleed, this is going to develop very quickly over the next hour or so. And then they're confused, lethargic, vomiting, don't know where they are, may have unequal pupils, and we think
One of
epidural.
our combat sports, temporal blow goes to the back of the head.
Yes, yes. Which, combat sports, that's sport. You have to have some rules, otherwise sports become too deadly. Lacerations. These are usually pretty darn severe because usually it's a knife or a bullet or something that has penetrated through the skull and went in and cut the brain. It is possible, I guess, that you could have it kind of tacked into place with enough tendons and blood vessels in one spot or ligaments or whatever, and not on the other, that it would shift and tear it. But usually this is penetrating trauma to the brain. Very severe, usually unconscious, and brain bleeding. I'm going to talk a little bit about cerebral perfusion pressure and all that. I don't have it in here, I'll talk about it at the end. So what do we call that?
Spiderweb.
Spiderweb. What do we think's wrong with them?
Head trauma.
They hit their head, yeah. So I have this patient and they've hit their head and they've hit this pretty darn hard to break the windshield. Now if this is a closed skull, but I have some bleeding inside of it, either the epidural or the subdural or a laceration or just bleeding into it with the swelling, where's that pressure gonna go?
On the brain.
It goes onto the brain.
Path of least resistance.
Okay, but if my skull is intact, that's a closed container except for one big hole. Where's the big hole?
Foramen magnum.
Yeah, the foramen magnum where the spine comes out. What's that base?
Cerebellum.
Cerebellum back here. Medulla oblongata. And what's in there?
Breathing and all that.
Breathing, pulse, blood pressure, vomiting. So I get hit here, boom. Shouldn't do that too many classes, I'll end up with CTE myself. Swelling happens, bleeding happens, pressure forces the brain, only place it can go, out the base, out the foramen magnum. Pushes down on respirations, pulse, blood pressure, vomiting center. What do our patients typically do with head injuries?
Vomit.
Vomit, there you go. Now as this pressure fills up here, the carotid arteries are bringing blood up to the brain. How much pressure is in your carotid arteries?
Quite a bit.
You know how much is in a brachial artery, right?
Mm-hmm.
How about a brachial artery for the average patient? How much pressure?
You're saying how much pulse pressure?
Well, how much pressure do you have in your brachial artery? The average patient?
120.
Yeah, 120 millimeters mercury. It's their blood pressure.
Okay, I'm trying to ask.
It almost sounded like a trick question.
I was
sorry.
about to ask, it depends on blood pressure.
It is their blood pressure. Now, how much is in the carotid? Probably more than that, because it's a bigger artery. But let's say 140. So when I have enough, and normally I have about, it's 5 to 7 millimeter, or 5 to 7 centimeters of water pressure. So I don't know exactly how that converts. But I have pressure here, and I have pressure here. When I get enough pressure in my skull from the bleeding, eventually I can't get the blood to go back there. There's just too much pressure to force up there. So it won't go. So what has to happen to get blood flow to the brain?
You have to reduce the pressure.
Well, I either have to reduce the pressure here, or I have to increase the pressure here. Now, the body doesn't have a way to reduce the pressure here, so it raises your blood pressure. So now I have my cerebral perfusion pressure, or intracranial pressure, and blood pressure. Normally blood pressure is more than intracranial pressure. But now that I've had the bleed into the brain, it's started to go up. And once my intracranial pressure, the amount of pressure in the skull, goes above the blood pressure, I no longer have blood flow to the brain. And we call that cerebral perfusion pressure. But now I don't have blood flow to the brain anymore. The brain's like, hey, I'm not getting blood, that's not cool. Brain's gonna tell the body to clamp down, shut the blood to the brain, raise the blood pressure. But what happens to the bleed now?
Just worse.
It starts bleeding again. Oops, now I've lost my pressure, I'm not getting any
Cascade
blood.
effect.
Boom. So I have increasing intracranial pressure, or ICP. And this becomes a thing. So you have the first thing, I get in the head of the baseball bat, and you check the blood pressure, and it's like, oh my goodness, it's 160 over 110. I was expecting it to be more like 80 over 40. It's the opposite of shock. Now, you would normally think, blood pressure up, pulse rate must be up, because that helps to raise the blood pressure. Except for putting pressure on the vagus nerves and all that.
Down causes put pressure.
Yep, so pulse rate goes down. But I've clamped down everything else so much and making the heart squeeze so hard that I'm still getting rises in blood pressure. So, blood pressure up, pulse rate down. That's like the opposite of shock. Bleeding into the brain. And at the point where we now have brain herniation. That means the brain is herniating, you're getting squeezed out the foramen magnum. That's not cool. Your patients do not do well with that. Now the other thing that can happen is your body can try to constrict and dilate the amount of, constrict and dilate blood vessels. So we've talked about the hypercarbic drive and the hypoxic drive, the CO2 and the O2. If I have too much CO2, my blood vessels dilate. Why do my blood vessels dilate? Trying to flush the carbon dioxide out of there. So your brain goes, I'm bleeding, I'm having problems, and will start to hyperventilate to get rid of the CO2 and constrict the blood vessels. That's cool. Until the blood vessels in the brain have constricted so much that I'm not getting enough perfusion anymore, and then they need to stop, and we end up with this cycle. So they'll start with, and then everything will be cool, except it's constricted so much it's not getting blood flow, and then the brain will go, and then what happens? CO2 starts to build up again. And now it's like, oh, too much CO2. Drop the CO2, but now it's causing some vasoconstriction, need to reopen the blood vessels, need to slow down my breathing. So you remember the breathing pattern?
Giant Stokes?
Giant Stokes. So you see that breathing pattern.
Say that again.
Giant Stokes, C-H-E-N-Y-E. Giant Stokes. So, high blood pressure, low heart rate, irregular breathing pattern, brain herniation syndrome. Oftentimes unequal peoples. Your patient is typically reduced mental status, oftentimes a Glasgow Coma scale of less than 8. So these are patients you can start ventilating. Now how fast should I ventilate? Remember, I want to make sure I have enough CO2 in the body so that the blood vessels don't constrict too much and shut off blood flow.
On the CO2, if you have a CO2 meter on the mask,
Ah.
you're squeezing it in, and as they're breathing out, you're seeing how much CO2 is coming out into the bag, and that way you can say, okay, oops, too much CO2, increase CO2.
Yep, that would be the perfect answer. If I could measure the end-tidal CO2, the exhaled CO2, and keep it right at 30, that's a perfect answer. Don't always have that available to us. At the EMT level, you're really not supposed to, but because, as you said, we always seem to work with a paramedic, paramedics do. So if you got it, awesome. If you don't have it, how fast do you ventilate? How fast do you normally ventilate? It's a patient
Every
that
6
is
seconds.
once every 5 to 6 seconds. How about somebody with a head injury that has brain herniation?
You want to
Slow it down?
slow it down.
Actually, no, because then the blood vessels all dilate and I bleed too much.
Okay.
So I got to keep it.
1 to 3.
It's 1 breath every 3 seconds. You're right, 20 times a minute. And with that, it should keep the CO2 level at about right, where I can have the blood vessels constricted enough to reduce the bleeding, but hopefully still enough oxygen going to the brain.
I'm remembering all this stuff. It's been 2 years.
Well, when we first kind of thought about this and figured it out, we're like, head injuries, hyperventilate them. So like everybody that so much has had a thump through their head, they're like, and now, you know, EMTs and paramedics can like ventilate 60 times a minute. So we were getting rid of all that CO2 and all that and just constricting those blood vessels. And then the brain was dying from hypoxia because their blood vessels were all constricted. So I said, let's slow that down just a little bit. And one breath every 3 seconds, 20 times a minute seems to be the magic answer. I mentioned the personality changes, so don't forget about scene safety issues. These patients a lot of times are very confused, don't know what's going on. And it's not a personal thing, but I'm suddenly driving down the road and boom, somebody hits me, and the next thing I know, I wake up and I have like these three or four big guys on top of me. Oh yeah, it's on until I know what's going on. And with the brain injury, they may not ever really figure out what's going on until, you know, a week down the road. So again, it's not like they wake up from this and they want to kill you. No, it's more of a, they are just no idea what's going on, and you're up in their face.
It's fight or flight.
Yeah.
Kicking in.
Yeah. Police officers are the ones that scare me.
And they get strong too.
Well, they do, but they have this firearm on them. So when one of them is in a wreck and they get knocked out, I'm like really nervous. I don't want them to wake up in the back of my ambulance and have them think something really big going on and pull their gun and shoot me. Not realizing what's going on.
If they're knocked out, you're transported, remove the weapon.
We do. Who removes the weapon?
Another officer.
Another officer, yes.
You don't touch it. They'll usually come in, they'll pop their sound belt, take the whole belt with them,
Yep.
and say, rest is yours.
That's a police officer training. They are comfortable with another officer taking their weapon from them. But me, they don't know me. I'm not in a police officer uniform. I'm touching their weapon, they are beaten. Do not let anybody touch your weapon. So seeing me and the weapon, instant deadly force situation. So let the police officer remove it. Now because we hurt the head, I'm worried the neck is injured. So we're almost always gonna have spinal precautions with this, with the C-collar, get somebody to hold the head there. We talked about the mental status is usually declined, so if we do the Glasgow Coma scales, we're almost 15. These are typically 10s, 12s, 8s, 6s down there, depending on how bad it is. Pressing on the brain stem, if we're having some brain herniation, they're gonna puke, so make sure your suction is ready, you've got that tested and ready to go. If they vomit, initially, if you've got C-spine and everything held already, you got them strapped to the board, you can tilt them on their side, let them vomit it all out, then suction clear what didn't come out, or even worst case scenario, use your fingers to help. Don't forget to assess the rest of the body, because even though they're involved in a car accident, hit their head, they may have a damage somewhere else with some major bleeding, so you need to take care of that too. And then there's some posturing things, which we'll see with this video. Yes, oh.
He just got knocked out.
Listen to the breathing. So when we assess them, we're going to palpate for the decap BTLS, feeling for any injuries, check the pupils because a lot of times they'll be unequal, indicating again swelling in the brain, and maybe even some brain herniation. Vital signs, don't be surprised the blood pressure's up, pulse rate is down, respiratory rate's kind of screwy, and the vomiting. You may have some posturing with it. What if your patient hit their head and has low blood pressure?
That means that something else is broken.
Yeah, something else is going on. They're bleeding somewhere. So then you need to figure out what other injury they have. Oxygen is not a bad thing for them. Don't be afraid to put high flow O2 on them until we hear otherwise. Just remember, if you're having to ventilate them, 1 breath every 3 seconds for the brain herniation syndrome. Otherwise, we're kind of the same for any other patient other than they may start seizing and they may vomit. So suction's ready, and if they seize, make sure they're not hitting their head on anything and transfer. So questions on head injuries?